Thank you, Gemma. Good morning, everybody, and thank you so much for inviting me to speak to you today. It's a real pleasure to be asked to come and speak at the Migraine Trust Public Day. So my name's Dr. Kay Kennis and I work as a GP in Bradford. I'm also a GP with a special interest in headache. Today I've been asked to speak to you about migraine and diagnosis. And this is obviously a really broad subject area. I know that members of the audience will all be at different stages of their migraine journey. Some people will be a long way along the road, and today I expect they'll be wanting a lot more detailed information, perhaps about the new treatments, which Dr. Davis is going to speak about later, or about how hormones affect our migraine, which Dr. Rusk is going to talk about, or perhaps a more rare variant of migraine called vestibular migraine, which Ria will talk to us about. But others may be right at the very start of the road and want a little bit more of a basic introduction to what is migraine. And so that's what I'm going to talk about this morning. So during this presentation, I'm going to give a brief overview. Why is diagnosing migraine important? And then I'll speak about what is migraine, both how it's classified scientifically and how we describe it more in real life situations. What exactly is a migraine attack? It's not just a headache, as I'm sure you're very well aware. What different migraine variants are out there? Because this causes a lot of confusion. Some people have very different migraines to others, and even within one person, the migraine attack can take on quite different forms. What triggers our migraines? And how do we actually get the right diagnosis if you haven't already? What investigations perhaps should be done to make sure the diagnosis is correct, if any? And then once you have been diagnosed, what should you expect in terms of your management plan? So starting with why diagnosing migraine is important, I know that I'm preaching to the converted today, but we are well aware that migraine is massively important. It's in the top 10 causes of years lived with disability, according to the World Health Organization. And we know that more than 3/4 of people can't actually function during an attack. It's incredibly disabling. And sadly, migraine tends to impact us most at the most productive times in our life, when we're often juggling work and family responsibilities. As a country, we lose 25 million days a year from work or school because of migraine. So it's massively important on an economic level as well as a personal suffering level. And sadly, we are well aware that only half of migraine sufferers are happy with their treatment. So there's a lot of work to be done in migraine still. This slide was kindly shared by Dr. David Kernick, one of my colleagues, a GP specialist in Exeter. And this gives a bit of background from migraine prevalence. So we know that more than 25% of women are affected by migraine at some point in their lives. And between 5 and 10% of men. And you can see the peak incidence here is around the age between 30 and 55, but 40s and 50s. And we can see that a lot more women than men are affected by migraine. And there's a huge sex difference here at the peak. But even into older age, you still find that there are more females than males affected by migraine. But I think this slide shows how common it is. So how do we classify migraine or headache disorders? There is an official classification, which I know many of you will already be aware of. It's called the International Classification of Headache Disorders, and it's now on its 3rd version. And the 3rd version was published in the first issue of Cephalalgia of 2018. And this classification separates primary headaches from secondary headaches. Migraine is a primary headache, and that means that it's to do with the innate characteristics of the brain itself that people get the headache. Other primary headaches are tension type headache and cluster headache, and there are some rarer ones. And this is different to secondary headaches. Secondary headaches are caused by other things, and the most common type of secondary headache we find is medication overuse headache. And it's important to know about that because medication overuse headache very commonly and sadly affects migraine sufferers. We try to keep going by taking painkillers. And once you've taken painkillers on more than 10 to 15 days of the month for 3 months, you can quite often generate headaches because of those painkillers rather than because of the underlying migraine itself. But other secondary headaches exist, and these include trauma to the head or neck, vascular problems such as strokes, non-vascular problems such as tumours or high pressure in the brain, toxic substances, in particular carbon monoxide is one not to forget. It's the silent killer. People who get headaches and they don't know what's happening and they don't think to check the gas fire. We can get infection causing headache, for example, as part of meningitis. We can get metabolic causes of headache, like problems with our salt balance or underlying conditions like diabetes or thyroid problems. And headaches can be caused by trouble with structures in the face, such as the eyes, the teeth, the nose. So when somebody comes to the doctor with headache, it's our job to try and figure out if it's a primary headache or a secondary headache by asking lots of important questions. So the ICHD3 then goes into a lot more detail about what actually constitutes a migraine diagnosis. And to have a diagnosis of migraine officially, according to this classification, you need to have at least 5 attacks that fulfill the criteria of B to D here. So you should have a headache which lasts between 4 and 72 hours. And your headache should have at least 2 of the following 4 characteristics. It should be unilateral on one side, it should be pulsing, it should be of moderate or severe pain intensity, and it should be aggravated by or cause you to avoid routine physical activity, just simple things like walking along or climbing the stairs. And during the headache, you should expect to have one of the following, either nausea or vomiting, or phonophobia or photophobia, or you can have everything. So the ICHD3 is very specific, and it is really helpful to have this classification so that we have got written down in black and white what a migraine is, and it gives a name to the disorder that we all experience. But sometimes in real life, it's a bit too strict. It's very helpful for scientific research because you need to know that in your studies, people fulfill the criteria exactly. But in real life, we slightly relax the classification sometimes. So when I would see a patient in my GP surgery or in my specialist clinic, or when my specialist nurse colleagues or pharmacy colleagues speak to people and make a diagnosis of migraine, we often ask other questions as well that give us some clues and lead us to the diagnosis of migraine. And this would particularly include the impact of the headache. So we know that if you have a migraine, on some occasions you will need to just lie down and crash out, whereas people with tension headache can generally carry on their normal activities even though they've got an annoying headache. People with cluster headache are even more disabled and very agitated and pacing with the headache, so that differentiates the cluster from the migraine. In migraine, we know that it's not just a headache. There are many other features. People are often nauseated and sensitive to light and noise, so that's a big clue. I often start my history taking by asking people about whether they had any childhood travel sickness, because that's another strong clue to later development of migraine. And if I'm seeing somebody in later life, I always ask if they've had previous migraines. It's more unusual to develop migraine de novo in older age, but if you've had migraines through your 20s and 30s and then they've disappeared for a bit and come back, it makes you more confident that the headache you're dealing with at that stage is migraine. We ask about triggers because we know that that's another unique feature to migraine. And we ask about family history because we know that there's a strong genetic tendency for migraine to run through families. So what's actually going on in the brain in migraine? So the problem is mostly centered around here, the brain stem, which is the oldest part of the brain. And it does lead us to speculate that perhaps migraine in older times could have been a protective phenomenon, maybe making sure that we stopped if we were overstimulated or if we hadn't had enough to eat or drink. And this slide has been very kindly lent to me by Professor Peter Goadsby. And this shows in more detail where we think the problem is in migraine. So it's here around the brainstem where most of the increased sensitivity of the migraine brain seems to be. So this area is called the cranial-cervical complex, and I like to think of it as a bit like a telephone exchange with lots of wires coming in and lots of wires going out. So nerves here release chemicals when they're stimulated, and those chemicals, those nerves can be stimulated by inputs from our vision, inputs from our neck, inputs from higher centers, for example, if we're stressed. And when the nerves are stimulated, they release chemicals, and those chemicals stimulate other nerves that cause dilation of the blood vessels. And when the blood vessels dilate, they release other chemicals that then feed back into the system and upregulate it. And you get a sort of snowball effect here. And then the nerves that are stimulated generate the pain response and the migraine follows. So we know for sure that migraine is a brain disorder. We know it's a very complex brain disorder. And we know there's nothing wrong with how the brain actually is structured. So if we take a brain scan of somebody with migraine and we compare it to somebody without migraine, those two brain scans look identical. But we know that the migraine brain is a lot more sensitive and it functions very differently. And when it becomes stimulated, it causes the nasty headache, but it also causes lots of other neurological problems, and they can be far away from the brain. So the nerves that get stimulated by the migraine attack affect other areas, including and very prominently affecting the gastrointestinal system, make us feel nauseated and off our food or vomiting. Another concept that I think is really important to understand when we're trying to figure out our migraine and how to control it is the concept that our susceptibility to getting migraine fluctuates with time. And I think this is something that I didn't know when I started managing headache. Sometimes our brains are very, very susceptible to triggering into migraine. And sometimes our brains are less susceptible to triggering to migraine. And this natural fluctuation is something that we don't understand properly yet. We know it exists, but we don't quite know why at some points in life we're more vulnerable and some points in life we're less vulnerable. And I wanted to explain this concept first before I go on to speak about migraine triggers, because I know that many of you will already be aware that there are certain things which will trigger off your attack. This list here is not exhaustive, But some of the common things that trigger our attacks are changes in hormones, which I know Dr. Rusk will speak more about later. Stress or release from stress. A lot of people will get their migraines at weekends. Sleep. We know having too little sleep is a strong trigger for migraine, but equally having too much. The migraine brain likes to have a very regular sleep-wake cycle, and sometimes we'll get migraines at the weekend if we sleep in too much. Not having regular meal times, not drinking enough, changes in the weather, certain foods for some people, alcohol, bright lights, loud noise, can all be triggers for migraine. And sometimes you don't just need one trigger. Very often you'll need a combination of triggers in this stepwise fashion before you generate a migraine. So you might need to be tired, not have had enough to drink, and then also perhaps be menstruating before you get a migraine. The problem is that the number of triggers that you need to generate a migraine varies depending on where you are in that cycle of fluctuation. So if you're in a very vulnerable phase of life and your migraines trigger easily, you might only need one trigger to get your migraine. Whereas if you're in a less vulnerable part of that cycle, you might need 4 or 5 triggers before you develop the migraine. And I think that's really important for people to know, because many people that I speak to with migraine are looking for that one thing that they could stop doing in their life and then they could stop getting migraines. And generally there isn't one thing, because there are so many different triggers before we get our migraines, and they interact so complexly. And also there are lots of triggers that we don't yet know about, or triggers that we know about but we can't control, such as changes in the weather or changes in our hormones. So what actually happens during a migraine attack? A lot of people, when they think of migraine, they think of this headache phase here in the middle. But we know that headache is only one small part of the migraine attack. So you start off with your vulnerable brain, which is largely genetically predetermined, and then you have a combination of triggers, and these triggers affect you at different times in your cycle of vulnerability. And when the triggers come, we can sometimes trigger into a migraine attack. And the migraine attack begins probably about a day or two before we're aware that we've got a migraine, before we get the headache, with this phase called the premonitory phase. And the changes that happen in the brain at this point, there are neurological changes, so we can get heightened perception, we become more sensitive to noise, to vision, to light, to smells. We get physiological changes such as retention of fluid, and we can get psychological changes. So sometimes we become more tired, sometimes we become more alert, and there can be food cravings as well. Interestingly, food cravings are part of the premonitory phase. People can often crave chocolate, and so they eat chocolate, and then they think the chocolate has triggered their migraine, but actually it's probably something that happened before then that gave them the craving rather than the chocolate itself. In many cases, there are some people in whom chocolate will trigger their migraine, but often it's the craving as part of the premonitory phase. So following from the premonitory phase, some people then develop this aura phase. Not everybody with migraine, as I'm sure you're well aware, not everybody gets aura. About 30% of people with migraine will get aura. And the aura it's something called cortical spreading depression. It's a wave of electrical depolarization that affects different areas of the brain. So if that happens in the visual cortex at the back of the brain, we get changes in our vision, and these can be positive or negative. So you can get positive changes such as zigzag lights or flashing lights, or you can get negative changes such as blind spots or loss of part of the vision. If the cortical spreading depression affects the area where sensation is controlled in the brain, we can get tingling, pins and needles, or numbness. Quite often that will affect one side, but sometimes both, and usually it starts in a distal area, so for example the hand, and then we'll move up the arm towards the face. But the cortical spreading depression can affect our speech, so sometimes our speech is slurred, or sometimes we know what we want to say, but we can't get the right words out. And sometimes the aura can be more complex and cause us to be confused or have other symptoms. And then following on from the aura, we go into the headache phase. And the headache obviously can be severe, but in many cases, it's not the headache that's the most disabling part of the migraine. For many people, it's the nausea, the vomiting, the poor concentration, and the continuation of sensory disturbances that cause them to have much more disability than the headache itself. And even following the headache, we know the migraine attack's still not over. We get this post-stroke where we can feel tired, we can lose the fluid that we accumulated during the premonitory phase, and we can still be off our food. Sometimes we can get the opposite and be more euphoric. And then we go into the interictal phase. So during this phase, the migraine attack's over, but that doesn't mean for everybody that they are symptom-free. There are a lot of people who persist with sharp stabbing headaches between their migraines and other symptoms. So that's the migraine attack, but we know there's lots of different types of migraine. So if I give you a couple of examples here. So we have Susie, who has monthly attacks of severe headaches, usually when she's on the first day of her period. They start with a zigzag disturbance in her vision, and then she'll get a severe throbbing headache, which makes her vomit, and she needs to lie in bed in the quiet with the curtains closed and sleep. And it takes her 3 days to feel back to normal. On the other hand, we have John. He has 2 severe headaches every month. Sometimes he can finish his day's work if he can take his painkillers quickly enough, but sometimes he needs to come home early. They put him off his food, he can't concentrate properly, and after 48 hours, he feels okay again. So who has migraine? Well, of course, they both have migraine, and that is another common query that I get in my clinics, is people saying, well, this can't be migraine because it's nothing like my mum's migraine, or it's nothing like my best friend's migraine. But we know there are loads of different varieties of migraine. It's quite an umbrella term. One of the main differentials is whether the migraine has aura or doesn't have aura. And we know that only 30% of people do get aura. And this is an artist's drawing of aura, which I've put up. I tend to find photographs of aura are quite distressing and difficult for people who get aura to look at. So hopefully this isn't too bad. Apologies if it is difficult for some people to look at. But as we've discussed on the last slide, the aura is due to this cortical spreading depression, and it affects different areas of the brain, causing different symptoms, usually before the headache starts. But there are some types of aura that are much more complex. So for example, I'm sure some people in this audience will get hemiplegic migraine, and that's where they actually develop one-sided weakness, either before or during the migraine headache. And people with hemiplegic migraine are obviously massively disabled by their migraine attacks. So we might use different treatment options for people with hemiplegic migraine. We may need to treat that more aggressively than somebody without the weakness. Similarly, basilar migraine is another rarer type of aura, and in extreme cases, people can actually lose consciousness. I'm sure there will be members of the audience that have this variety of migraine, and it's a difficult one. And we do have rarer other types of migraine with aura. But there's many more different varieties of migraine than just having aura and which sort of aura you've got. Migraine can become complicated, and one of the most difficult complications is when people develop chronic migraine. Chronic migraine simply means you're getting migraine on more than 15 days of the month, and 8 of those days have to have typical features of migraine. We don't know why certain people go on to develop chronic migraine. We can only diagnose it once people have stopped all their painkillers completely for 2 months, because medication overuse can sometimes be misdiagnosed as chronic migraine. Status migrainosus is another complication where the migraine attack just doesn't finish after 3 days. Sometimes it's just the headache, but sometimes you get neurological symptoms that persist, so perhaps a droopy eye or something. Obviously, you'd need further investigations to ensure that this was status migrainosus and not something more serious. Again, a difficult migraine to treat. And we can get episodic syndromes that are associated with migraine, just to complicate the diagnosis even further. So one of these is vestibular migraine, which Ria is going to speak to us about in a lot more detail later on. So with all these different variations of migraine and the different ways it can present, you can see getting the diagnosis right can be a real challenge. And I am well aware that as a medical profession, we do not cover ourselves in glory here. And I know it can take a really long time for people to be given the right diagnosis. I think it's really important that whoever you speak to about the migraine, to get your diagnosis, whether it's a pharmacist, a nurse specialist, a general practitioner, or a secondary care specialist, that there is enough time for you to be able to go through the full story of your migraine, because the history is absolutely the key thing that we need to elicit. The tests are not helpful, as we'll come on to in a minute. So when I'm in my GP specialist headache clinic, I have plenty of time and I can go through the full story. I ask about symptoms people had when they were children, whether they got travel sickness. I ask about their current headache features and any new changes. Sometimes very different migraines will need further investigation if they're completely different features compared to what a person's normally been used to experiencing. I ask about what can trigger off the headache. I ask about how the headache is impacting people, because that impact of the headache really helps you to decide what kind of treatment is going to help the most. I ask about other medical problems that people have and mental health problems, because sometimes if the other medical problems are not managed properly or the mental health problems aren't managed properly, then it's difficult to get control of the migraine. And sometimes the treatments for those other problems, or just the diagnosis itself, can prevent you using certain treatments that you might normally want to use for migraine. So for example, an asthmatic person wouldn't be put on a beta blocker, propranolol, to prevent their migraine. Family history is important. You don't always need to have family members with migraine to have a diagnosis of migraine, but if there is a strong family history of migraine, then it leads you to suspect that migraine's perhaps the more likely in the person that you're seeing. We ask about what tablets people are taking, both over the counter and prescribed medications, and if they're using any street drugs or alcohol or smoking, because all those things affect our management decisions. And we ask about lifestyle as well, including whether people are under a lot of stress, whether they have time to eat regularly, whether they can exercise, whether they're drinking plenty. Because all of these things affect how we help to manage them. And what tests should be done? As I say, the history is key, and often when we get a clear history that tells us that somebody has migraine, we don't actually need to do any further tests. A lot of people do still wish to have a brain scan done because they feel frightened there might be something else going on in the brain. And I think it's important to know, and I'm sure that most of the audience is already aware, that brain imaging can unfortunately do more harm than good in somebody who's got a clear clinical diagnosis of migraine. So if we were to scan 100 people, between 1 and 10 of those people would have an abnormality on the brain. And very often it's a minor thing. It's a little white dot. It's a blood vessel that's blocked off, and it doesn't mean anything. But unfortunately, in some rare cases, the abnormality is quite major. It's not causing the migraine, but it needs to be discussed with the person whose scan it is. And it might be something sinister like a dilated blood vessel, which we call an aneurysm, or another problem. And sometimes these sinister problems can't be treated. So your poor patient goes away with a diagnosis of migraine, but also the diagnosis of another neurological problem that perhaps can't be treated. And then they've got the worry of that on top of the diagnosis of migraine. So we do try to avoid doing scans unless it's necessary. Similarly, blood tests are not usually needed, but sometimes we do need to do them. In somebody over the age of 50, when they first present with headache, we tend to check for a condition called giant cell arteritis with some blood tests. And in people with chronic headache, we would usually just ensure that there wasn't an underlying metabolic cause for that by doing some blood tests as well. So if you're in the audience today and you're here because you think that you might have migraine, but you haven't had a formal diagnosis yet, these are just a few little tips, perhaps, to think about before you go and see your GP. Number one, I think it is worth saying, look, you've done some research yourself and you think this is migraine. It gives your GP the heads up, puts them on the right track, and also makes them realise that you think this is a primary headache disorder and you're not going there worried that you've got anything more sinister going on. The other thing I'll do is always emphasise the impact of your headache. I have many people who've been misdiagnosed as having tension type headache because they've played down the impact of their headache on them. Definitely keep a diary for 2 or 3 months before you go to see the GP and jot down how many days of the month you're getting the headache on, and when you take painkillers and whether the painkillers help. Perhaps not a very complex diary because time can be limited in the GP surgery, but something simple is very helpful. And having listened to the talk today, you will be aware of the likely questions that you'll get answered, and I think that can help you to think through your answers to maximise the best use of the time that you have with your doctor. So when you have been diagnosed with migraine, what should you expect? You should definitely expect that the diagnosis should be explained to you properly, and you should be reassured that the doctor or pharmacist or nurse has thought about sinister causes of headache and they've excluded them and why they've excluded them. You should feel that the impact of your diagnosis has been acknowledged. It's a massive diagnosis. It's a chronic condition. But with the right self-management and help from the medical profession, the impact on your life should be minimised as much as possible. You should come away with a shared management plan, including how you can help yourself as well as medications that you can take. You should feel like you've had the opportunity to ask questions. You should feel like you know where to go for further information. And you should expect that the person who made the diagnosis would want to follow you up and check how you're getting on with the management plan. And I think if these things haven't happened, it's absolutely reasonable to ask for a referral to somebody who has a special interest in headache and perhaps has more dedicated time to help you with that condition if you feel like your management hasn't been properly addressed. And finally, always be kind to your brain. Make sure that you are eating regularly, drinking plenty, managing your stress, exercising, and minimising the triggers that you know about as best as you can. So thank you all for listening today, and thank you to Professor Goadsby and to David Koenig for a couple of the slides that I've used in this presentation, and also a big thank you to my camping friends who sent me lots of questions that they thought they would like to be included when they were hearing about how to diagnose migraine.